just I want to comment in your comment. Just I want to show that our data, to be honest, I agree with both Dr. Anov and Dr. Ahmed, and I think they are saying the same things. But just I want to alert you that the overall survival for our patient is 65%. It is not 89% as the state. So now we should combine our like modality, so radiology and as well as the medical oncology. So the only data among the Saudi women, yeah, it is old, yeah, it is 1994, it is 65%, so it is almost 30% less than the American women. So I think we have to be. Why is that? Because maybe. Why is that? Because medical oncologists maybe they are not as good. Maybe because radiation oncology they are not that good. Sorry, surgeon. So we need to help each other. We need to combine.
Okay, can I? I need to respond. In Sweden, okay. This is a very good country who has an excellent program for screening. The early breast cancer jumped, the mortality never changed. So if we cannot reach, let's be, in 10 years time we'll not relapse within Norway. Screening did not reduce their mortality. Okay? That is again a fact by one of the two best European countries. So I don't like it.
Working in Jeddah, in private sector. This one is a well-known breast surgeon in Kingdom. He will talk to us about the controversy of surgical management and the guidelines.
Thank you.
People come to your clinic, they want to know they don't have breast cancer. What you will do? You have to do mammogram. You call it screening, you call it checkup, you call it anything. You have to do mammogram or ultrasound or MRI. That was my comment. Okay. Now, our controversy in the management of locally advanced breast cancer. To me, one of the most difficult part. Why? Because decision is not me, is not oncologist, and most of the time is the patient, and is not patient alone. We all know what is the locally advanced breast cancer. Size is important, yes. I'm not going to say what is the size, because to me the size is different. There is no, don't say it's 3 or 2 or 2 or 5 centimeter or 4 centimeter. No, I can consider 3 centimeter in a small breast as a locally advanced, and I can consider 5 or 6 centimeters in a big breast as a breast reduction surgery. And we are doing a lot of this. So the size is a little bit different. Metastasis several lymph node, this is to me the most important. Why? The most important difficult part is the lymph node dissection, where I'm sure in a patient with large lymph nodes, they will get lymphedema at the end, which I hate it, really. The third thing is what? If the tumor is invading what? Skin or the fascia below. And the skin, probably the nipple also. Everything has its own criteria and its own way of management. We'll go through this. Now basically, when I say locally advanced, somebody call me, Adnan or somebody, say, we'll send you a locally advanced breast cancer. We have many things to think about. Number one, am I gonna start neoadjuvant chemotherapy or not? And if not, I'm gonna do a subcutaneous mastectomy, nipple sparing or not? Am I gonna do lumpectomy and breast reduction in the same side or not? Axillary node dissection, and please, I know maybe in the data is a little bit different, but here, if you decide to go for neoadjuvant chemotherapy, I think the best way is to do sentinel lymph node before you start. Why? We know the effect of chemotherapy on the lymphatic is fibrosis. I was surprised many times after neoadjuvant chemotherapy that there is no dye. I injected the dye, and I'm not seeing and I'm not hearing silver colloid, neither the methylene blue or all them. So do the sentinel lymph node just before, okay? If I take it one by one, let's go to the first thing, neoadjuvant chemotherapy. Is it good or not for locally advanced to start with? You know, it's unfortunately, the locally advanced breast cancer still in Saudi Arabia is high, and still we see it in a young population. Preoperative systemic chemotherapy, initially used for locally advanced breast cancer, has become more common for patients with operable disease. صح? But again, don't follow numbers. Don't find Roche fi Roche, you know? Don't follow Roche or Sanofi. Now, I tell you, this is a true story. They can give you a number, convince you to start with chemotherapy, and then you do surgery, and then you go back again to chemotherapy. It's all not, and I don't know, it's not solid to me. Second thing is in patients with operable breast cancer, randomized trial have demonstrated that preoperative systemic therapy and postoperative chemotherapy using the same agent will result in the same disease-free survival rate. In Saudi Arabia, as I mentioned, it's still common. This is a study we made it when we were in King Faisal. Dr. Azzuddin Ibrahim, mashallah, he's leader في study يعني هو سباق في كل شيء. And we are the team. Dr. Yasser Bahadur, Prof. Yasser Bahadur, وأنا كنا دائما for 9 years or 10 years together at the oncology group. We reviewed some of our cases there. I'm not going to go through the study because I'm not here to talk about the neoadjuvant, but I'm going to see the effect of the study on my decision on the surgical part. Okay? So medical record was of 64 patients were studied. Locally advanced breast cancer, non-inflammatory invasive breast cancer. So we didn't include the inflammatory breast cancer. The median tumor size was between 2 and 15 centimeters. Now, this is the important part of me. All patients receive preoperative chemotherapy. All tumors have central marker before starting again. And I think we're all doing this. Huh? If you want to start neoadjuvant, you have to put markers in the middle before we start. Otherwise, we may lose the site of the tumor. Let's go now to the timetable down. We did mastectomy or modified radical mastectomy to 60% of the patient. And we did lumpectomy and axillary node dissection to 40% of the patient. So 40% we preserved their breast. Clinical remission was in almost 30%. Partial remission, partial clinical remission in almost 50%, and the rest were same or progress. And this, see, the way it's written, same or progress. This is the most important thing. Now, this is equivalent to what you gain. You lost 30%. Why? They progressed their disease in 2 or 3 months. Maybe they would benefit if you do mastectomy first. The median largest residual tumor was 1.8 centimeters, so it's around 0 to 8 centimeters. About 20% was complete pathological, which is good. To me, it's really good. Microscopic residual disease in 28%, 30%, and macroscopical in 52%. So what is the result for me and the conclusion? The presence of estrogen receptor, I don't care. For the surgery, I don't really care. I know it's effect and very important for the oncologist people. But I will go, I'll go to the last paragraph. Despite the use of a standard multimodality approach in the management of patients with locally advanced breast cancer, prognosis remain the same. You agree all? Cancer cell response, this is what important for me in surgery. The cancer cell responds to chemotherapy by decreasing cellularity, fibrosis, and shrinking toward the center of the tumor. So they shrink. may leave small islet of cancer cells behind with a negative margin. That mean what? That mean I do lumpectomy, I'm happy, negative margin, but actually I left part of the disease that I cannot see it in MRI or I cannot see it in mammogram. 59% of the patients received preoperative chemotherapy still needed mastectomy. And 49% of the patients needed adjuvant chemotherapy after surgery. And this is, again, we have to consider it. Still, we said chemotherapy still needed and mastectomy in 41% of the patient. And patient is still, the patient needed adjuvant chemotherapy after the surgery. Part of him, we have still 40% of this patient who did mastectomy still needed chemotherapy after. See how much chemotherapy the patient is doing.
There's no evidence for this practice. There is no evidence that you need to give chemo after mastectomy. None. You know?
Oh, well, we can go and discuss.
How do you end up after 40% will have chemo after mastectomy, after neoadjuvant?
Yeah.
My colleagues.
Unless they did not complete the neoadjuvant,
No, I'm talking
8 cycles or 6 cycles.
I'm talking about full neoadjuvant chemotherapy followed by mastectomy. I mean,
It's not standard of care at all.
That. We can go and discuss this paper later. Actually, this is only an introduction to our surgical point of view. And, yeah, it is very high number, and to me was really surprising. That's why it make me a little bit worried about giving you adjuvant.
We'll discuss it after the lecture.
24 patients did not respond to the preoperative chemotherapy, and the response of the lymph nodes by fibrosis will raise up the question of the need of preoperative or pre-chemotherapy sentinel lymph node dissection. With a relatively high number of residual axillary lymph node after chemotherapy, the need for lymph node dissection in a palpable lymph node still there. Most of the things we mentioned there, it's already solved. Okay, so if I give you a different scenario. Number one, right breast cancer, 40 years old, 3 centimeter, invading the skin in 1 by 1 centimeter. 1 centimeter is attached to that tumor. No suspicious lymph node. What we will do? معلش غسان I will ask لأنه it's part of my lecture يعني حتى عشان controversial. What we will do? If this patient came to you يا أم الخير 3 centimeter invading the skin in an area exactly 1 by 1 centimeter. This is true cases, by the way.
This is T. Is it
T4B?
T4? It is T4.
B.
T4, yeah, because it's important.
Do you think the patient will benefit more from chemotherapy, or I do lumpectomy, sentinel lymph node, and the traditional? Because lumpectomy, by the way, when we do lumpectomy, we do elliptical incision of the skin, and we take at least.
The tumor, what is it? Is it a triple negative breast cancer?
No. I should have written everything. No, it's not triple negative. But again, I'm talking about the surgical point of view. Now, to me, if I do lumpectomy, and I can go to literatures, there will be no difference if I do preoperative chemotherapy or postoperative chemotherapy. It should be the same. If a patient ends up, to me, I will do lumpectomy and sentinel lymph node. And maybe if he end up by going to Al Khair, she will do preoperative chemotherapy. And both is acceptable.
Yeah, but this patient, there's invasion of the skin. This means this patient, she's T4 and supposed to be candidate for neoadjuvant, not for lumpectomy.
No. Here, this is the controversial one I talked about. Is candidate, just a second, Doctor, is candidate for neoadjuvant? Yes.
Okay.
But is not candidate for lumpectomy? No. There is nothing to stop lumpectomy. Yes. Is candidate for neoadjuvant? Yes. And our patient, yeah.
Probably you can.
Absolutely, yes. This is my point.
You want to ask me? If this is luminal, if this is
Luminal A. Yes.
I will ask you to operate first. If it is
But this is why I
basal
ask
or
all the time.
I see her first. So I think when you say breast cancer now, it's not acceptable. You have to tell me what breast cancer. Luminal, I send it to you, and I fully agree with you, lumpectomy.
Yes.
If it's really HER2 positive or basal-like, send her to me.
Absolute. Yes. Next case, breast cancer 4 centimeter. Right? ER positive, PR positive, HER2 new negative, grade 3, no suspicious, suspicious lymph node. Yes. What you will do? Suspicious, I mean, is not matted lymph node, by the way. Suspicious is
by imaging or
imaging. Sorry. Do you do lumpectomy? Do you do neoadjuvant chemotherapy, or do you do what do you do? Any suggestion, Mit'ab?
So 4 centimeter. This is T2. She has suspicious lymph node, so I think we need to complete our investigation first by
Biopsy positive.
Yeah, biopsy.
FNA lymph node positive.
Yeah, so it depends on the breast size.
Thank you. This is my point here. It's all depends on the breast size here. If I see the breast size is small, I'm going to send her for neoadjuvant. If large breast size, we will do lumpectomy.
The evidence by the German group, they are categorized the patient based on the tumor size. They are giving the patient more than 6 centimeter chemotherapy.
This is German يا دكتورة. أنا I don't believe in German من أصله أصلا. حتى المرضى اللي عندنا اللي يروحوا German I don't believe in them للأمانة. يعني. Case number 3. Yes. No. I'm by the way, دكتورة.
It's concurrent by the Dana-Farber if you are not believing it.
Yes. The lecture here is the controversy I get myself, okay, during my practice when the patient come to me. Case number 3, breast cancer, 6 centimeter, central, nipple is involved or retracted, no suspicious lymph node. Yes?
If it's a large breast, we can do central lumpectomy.
That's number 1. Yeah, but 6 centimeter central lumpectomy, it's over. ليش؟ لأنه أنت you need margin. فyou're talking about 8 centimeters. فمعناته إيش؟ What I will do؟ للأمانة most of the time I will still end it by doing mastectomy. صح ولا لا؟ The nipple is involved, I'll end it by doing it. So it's either I will do modified radical mastectomy or I send her, she will do neoadjuvant. For me, probably it's better to do neoadjuvant chemotherapy for this patient.
What we can do after neoadjuvant?
Central lumpectomy. I agree with you. But usually, ما حد يقدر in this case. The case after, breast cancer 3 centimeter, invading posterior the fascia with a suspicious lymph node, neoadjuvant. I'm not going to operate to take the muscle in the wall. صح ولا لا? Hey, we're not going to operate. Small tumor, yes, but still I'm not going to take the risk of taking the pectoralis major معايا and fascia. Surgical option, subcutaneous nipple sparing mastectomy. Now, if we decide to do mastectomy for the patient, there is a big trend nowadays from the patient requesting to do the subcutaneous nipple sparing mastectomy. I'm surprised because this is a very common procedure, by the way, in the Western, in America or in Europe, but not common here in Saudi Arabia. Lately, especially in the last 1 year, and I think it's Angelina Jolie syndrome, most of the patients, they are requesting this. They come to, especially 40 years old, requesting to do subcutaneous. So we are doing a lot. Now we start to do a lot of these cases here. MRM with a tram flap or LD flap. Let me tell you, I hate tram flap. I know one of the commonest, by the way, but I hate it. Why? There is a lot of problem for the patient. You're gonna, you know, in the tram, by the way, skin with the muscle, patient will come to you, incisional hernia, weak abdominal wall, bulge from here, pain from here, a lot of complications. To me, the best thing you do, LD flap or put an implant. An implant, and I really prefer it. It's very easy, just to take it whenever you want and put another one. Lumpectomy and axillary node dissection, yes. If any tumor large, but the breast is large, yeah, we can do lumpectomy because most of the patient will benefit from breast reduction anyhow. Sentinel lymph node, always before neoadjuvant chemotherapy. Please. As a conclusion, see, we don't run a lot of time. You know, I'm on time. As a conclusion, the breast size is important in deciding the need for lumpectomy or neoadjuvant chemotherapy. And again, the breast size is very important. يعني don't be surprised in I start patient on neoadjuvant chemotherapy على 2.5 or 3 centimeter breast cancer when the breast is really small. Neoadjuvant therapy can give 40% chance to save the breast by downsize the tumor and make it suitable for lumpectomy. We all agree on this. Actually, we are looking for this. Sentinel lymph node biopsy should be done before neoadjuvant chemotherapy. The surgical option should be explored to the patient and she will decide. We'll sit with her. I أقول لك الأمانة what I'm facing. They hate chemotherapy. They can go to surgery. عندي by the way record. يعني عملت interviews with the patient صورتهم 10 patients كلهم يقول I can operate 10 times but not a single cycle of chemotherapy. We all know this. يعني let's aim all to reduce the chemotherapy, not to be happy to increase the amount of chemotherapy. روش والله ما حيجيبوني بعد كده. نرجع مرة ثانية. This is my favorite. أبو القاسم الزهراوي هذا أبو القاسم is probably the first oncology surgeon or breast surgeon قبل 1000 سنة. And this is documented. He's the only and the first oncology surgeon موجود probably في العالم كله. What he wrote: متى كان سرطان في موضع يمكن استئصاله كله كالسرطان الذي يكون في الثدي إذا كان مبتدئا صغيرا فأخرجه بجملته. wide local excision. This is what we are doing. أما متى تقدم فلا ينبغي أن تقربه فإني ما استطعت أن أبرئ منه أحدا ولا رأيت قبلي غيري وصل إلى ذلك. عارف إيش معناته؟ He didn't mention anything about chemotherapy. Useless. Thank you. That's it. Thank you. Question بعد.
I'm sorry actually, because actually mine is the last lectures was actually by chance. Dr. Ahmed Sher is not around, so actually I'm going to refute everything surgeon says.
طب خليني أجيب لك قهوة. Oh, Mike. I take it home.
Thank you. طيب السلام عليكم. So I'm a hematologist and a medical oncologist. I'm proud of both. Oh, sure. Now, actually, it's by pure luck. I was supposed to be speaking the last lecture of the day, قبل العشاء prayer, and I've told them actually probably going to find no time. It's just actually maybe the good luck of Dr. Ayman or the bad luck actually for Dr. Ayman. We're going to see now. Now, here's the most important thing. One of the smartest surgeons ever was the head of the American College of Surgery in the 1970s. I forgot his name. Actually, the guy was so smart. He is one of the first one who actually made the argument actually that radical mastectomy is not better actually than actually lumpectomy and axonal node dissection. Now, here's the thing. He's a smart surgeon. It's not about a bigger surgery. It's not about a huge surgery. It's about a better surgery. Now, I'm just going to try to make the argument, neoadjuvant, going to give you actually the option to do a better surgery. So you should be thankful to us. Okay, now, I'm actually have a bit of like southern taste. So actually you're going to see actually, I make the argument like George W. Bush. Just make my argument and you just need to find actually the evidence for that afterwards. So here's the question we need to ask about the neoadjuvant chemotherapy. So the simple idea, just make diagnosis. Actually, I'm just going to see if I can make a laser pointer. So diagnosis, surgical resection, then you give adjuvant systemic chemotherapy. Now, adjuvant systemic chemotherapy is as important as your surgery, especially in the locally advanced disease. This is what saves the people's life. This is what saves the people's life. This is what we have clear evidence about. Now, nobody argues about the surgery, but we don't have a randomized controlled trial. I'm not saying surgery is bad, but I can tell you there's a very solid evidence about chemotherapy. So do not mess with chemotherapy. It is a cornerstone. Now, let's see actually what is the value for the new adjuvant of chemotherapy. So people say, I'll make diagnosis, I'll make a new adjuvant, then surgical resection, they will consider radiation, hormonal therapy, whatever you want to make afterwards. Or you want to split your chemotherapy pre and after. Now, the new adjuvant chemotherapy has been always considered for the locally advanced T3 to N2 and 3 disease. Everyone will actually say this is acceptable. You could not do a good surgery, you could not do a good negative margins. So that's why you should give a new adjuvant. I'll make the argument for you, even for earlier breast cancers, chemotherapy might have a role, and you're going to see the argument for that. Now, new NCCN guidelines, I'm just going to make it put up front. So they actually advocate for new adjuvant, especially if you have a HER2 disease. And actually, we're going to come to the evidence about that. So this is a direct copy of that. So inoperable, locally advanced breast cancers, which is clinical stage 3A and stage 3B, actually they advocate clearly that you need to give a chemotherapy. Nobody argue about that. This is a good idea. You downstage it, you go ahead and do it. If you have a HER2 disease, this is always a good idea. Herceptin, actually, trastuzumab, plays a great role actually if you have a locally advanced breast cancer. So it's going to downstage your cancers and you go ahead and actually resect it. Now, but what's more interesting, actually, they do include T2 disease. Now, people might think this does not make sense. If you have an early breast cancer, why should I consider like a new adjuvant chemotherapy, very operative systemic chemotherapy? Surgeons will be unhappy, will say, oh, I'll go after this, I'll resect it. If you think chemotherapy role is only to downstage to make the surgical easier, that's wrong. Chemotherapy has much more role than this. It's going to tell us a lot about the patient. Okay, now, there's no great science about the perioperative chemotherapy. So whatever actually has been used as an adjuvant, people have used it as a perioperative. So basically people use the same aggressive chemotherapy for locally advanced breast cancer. So people actually will use the AC, the docetaxel. If you have HER2 disease, we will use AC Taxol with trastuzumab trastuzumab and Taxol treatment. There's no great science. Whatever you use an adjuvant, we're going to give it as a new adjuvant. But now what's the extra evidence? What's the extra benefit I'm going to give you actually as a new adjuvant chemotherapy? Now, the simplest thing, as I'm going to say, people say, I'll make it operable. So increase the rate of breast conservative therapy. But actually, there's more than that. Actually, it's going to be also improving the prognosis. We think, actually, I'm going to show you some studies that actually in HER2 disease, if you start to give this perioperatively, actually, you're probably improving the overall outcome. So do not mess with the HER2 disease if you have the chance to give them a new adjuvant chemotherapy. Now, not only that, I'm going to have a better idea about this patient prognosis, and we're going to discuss that. I can tell the patient this is an in vivo experiment. This is a true life experiment. I give them chemotherapy, and I know actually what's going to happen to the patient. The one who responds versus the one who doesn't respond. Now, to allow the patient to start earlier. Now, tell me, how soon you can get a surgical booking for a surgical operation? If I get to see a patient today, surgeon will tell you next day. That's not true. I'm willing to show you actually my own institutional data. 4 to 6 weeks. Now tell me if this is going to be acceptable. If the lady does not like to start chemotherapy, she will be happy just to wait for a month before she's going to get her booking for the surgery. Now reduce the extent for the surgery, and actually you might spare the patient to have a morbidity from the surgery. Axillary node dissection, 10 to 15% lymphedema. All of you have seen a lymphedema, what's going to do at the end? It's a catastrophe. When the patient just loses her arm, yes, it's an arm, very dysfunctional. Now, the question is about disease-free survival, overall survival, and correlation with the pathological response. That's a big question, which is we don't have a perfect answer, but I'm going to try to answer this. Now, here's the question. The problem with most of the new adjuvant study we're going to discuss, their endpoint was pathological complete remission or pathological complete response. Now, this is unacceptable, but the problem, that does not mean it's related to a better overall survival if you do not select your population. Now, the status of the lymph nodes is always going to be a controversy. So if you have an early breast cancer, should you do a sentinel or not? If you had a query suspicious, should you go a full axillary dissection or not? This is still actually out. The jury is out for discussion. Now, the in vivo response to chemotherapy is a great antitoxicity I'm not going to touch upon. Now, here's the problem actually we're going to face. Now, there's a different definition for pathological complete remission. And actually, I'm going to come to explain why this is actually very crucial for us. So for us, for the surgeon, if you see complete PCR, that's enough. No, it's not enough. And I'm going to show you the evidence. PCR is quite different among different groups and actually does correlate with a different outcome. So some people will use absence of invasive cancer. Some people use absence of invasive cancer in the breast and in the axillary lymph node. So primary tumors, primary versus lymph node. Some people actually use absence of invasive and in situ carcinoma. So there's a high degree of concordance between the different definition, but there's a different definition can actually define different favorable cases. Now, I hope I put the right slide on the same. So let me actually jump. Okay. So actually, this is actually one of the greatest papers I have been discussing that issue, 2012. So definition and impact of pathological complete response and prognosis after neoadjuvant chemotherapy. Now, so they went actually in a large population base. They went down and tracked actually their exactly pathological response. So actually, now you can just see the curves. They're completely overlapping. Now, the only best actually one, actually, I know it's actually not the greatest one I should show here. When you have a complete disappearance of the cancer, this will come with a better outcome. But you know actually what's going to even give you a better outcome? The one at the bottom? Actually, it's not one actually, it's actually your complete response to the chemotherapy. So if I know which lady can respond well to the chemotherapy, I can predict she's going to do well. Now, this does not need a magic, but imagine the surgeon removed the cancer first. To be honest, it's a black box. I wouldn't know actually if this lady can respond well or doesn't respond well because I don't have an evidence of measurable disease. Well, now I have a great response. Now, am I going to be able to change her future? Probably not. I don't have yet the mechanism to do that, but maybe in the future we're going to be able to select those ladies for more intensive therapy. So in vivo experiment is one of the greatest way how you can tell the future how it's going to happen. So surgeon, please slow down before you're going to take any tumor out and discuss it with medical oncologists. Tumor boards are meant for that. I'm always going to say, I'm not like for determinant, I'm always saying like the surgeon, like to rush things in, take the tumor out. No, this is not a good idea. Discuss it. There's many things, and I'm going to show actually the other benefit of the other treatment. Okay, now, I'm sorry, now let me touch on this issue. So one of the biggest problems when we talk about complete pathological response or just response. Now, I'm just going to show you, now when you have a BCR versus actually residual disease. Now the problem with residual disease actually it encompasses a lot of things. Responsive cases, some cases which remain to be stable, and actually failures. Unfortunately, actually, some of the failures will be also actually combined here. I mean, going to be included here. And that's the problem why actually the response to chemotherapy does not predict overall survival. And that's why we need to be a more specific definition of what you call the BCR. Am I good in time or? Good. Right. So actually, let me just convince you, if you have a HER2 disease, please do not touch. Please do not touch. I'm going to say it again. Give them very operative anti-HER2. I'm going to just show you the evidence for all that. So BCR positivity with the HER2 disease. Now, if you just include any HER2, now unfortunately this is the small trials before I'm going to talk about the large trials. And this has been done in a meta-analysis. Just shows you actually, if you add actually Herceptin in a small population. Now remember, Herceptin came to the market late 2004 and early 2006. So this is really all like small things. This just shows you, add any chemotherapy with the Herceptin, it's going to work well. And you're going to increase the rate of BCR. So please be cautious when you have a HER2 disease and try not to push it straight. I mean, unless it's the perfect scenario. Try not to push it straight for chemotherapy. For surgery. Now, there's a 3 large neoadjuvant chemotherapy, and it's all with the HER2 disease. This is one of the largest trials actually which has been done. New Sphere, New Alto, and the Gabriel Quinto. Now, all of them shows actually a great response. Actually, let me just try to highlight this for you. So, pathological complete response, 39%, 46%, 21.7%, no cancer, remove it all. So, HER2 disease, please do not touch and send it to the oncologist. Now, what about the sentinel lymph node issue, which is always comes? So you might imagine, I have a big tumors, I give chemotherapy, everything disappeared. Should I go after the sentinel lymph node and maybe the axillary lymph node, despite I might actually a proven fact that the axillary lymph node was involved? So, what is the aim of the sentinel lymph nodes? We should always ask ourselves, is to try to spare the presence of axillary lymph node dissection. Now, if the patient receiving a new adjuvant, do we have any real evidence to guide us how to do this? To be honest, no. So the problem, the sentinel lymph node, actually the evidence for that came from large surgical series. Actually large means like thousands. And it showed actually it's the same outcome. But the problem with the new adjuvant, we are changing the physiology of the case. That's why we need to ask ourselves, do we have the evidence for that or no? Now, there's only a census guidelines on this, and I hope I did it actually. Anyways, now the 2 options, people will try to do a sentinel lymph node, but that's when you're going to do 2 procedures, one for the sentinel lymph node to stage it, or actually the one which is you're going to do it with the major surgery if you're going to give a chemotherapy. Now, so let's be clear. most of the larger tumors, actually we're going to be talking about, they're going to require chemotherapy regardless of your sentinel lymph node status. So, and most of them actually, people will, like the case number 3, Dr. Ayman have argued, there's a central mass retroareola, so it might be not relevant. But to be honest, it's going to be relevant when you have a high rate of pathological complete remission, when you have nothing much there. And unfortunately, X-rays, imaging is not very sensitive to pick up a complete pathological response. PET scan might be of a good idea, MRI might be of a good idea, but using a CAT scan, necrosis and inflammation is going to show the same dimensions. So I don't have a good answer for that. Now, downstaging of the axilla, actually you can see that. So this is actually came from JCO in 2009. So actually, downstaging of the axilla is actually can happen if you have a complete response. 93% of the time, we are talking here about complete pathological response in the primary tumors. So the axilla always follow. So if I can shrink down the primary tumors, the axilla always follows with that. Now, unfortunately, it doesn't happen if you still have some residual disease in the breast. Now, we should always remember, not all breast cancers are the same, and not all of them can respond the same. So here's the argument which Dr. Ahmed was trying to make. So luminal A, if I try to give chemotherapy, not a smart idea. The reason for that, a small series actually which shows actually 7% will gonna only respond. For HER2 disease, if you give an anti-HER2 including the regimen, actually it's a great response, 45 and 36. I'm sorry, using this is FAC and this is AC. Now triple negative, you have no other option, remember that. So chemotherapy is a great way. Now, we keep talking about foreign experience. Now, this is actually our experience from our own institution. So we decided to look in our new adjuvant regimen. So we divided them if you have a HER2 positive, HER2 negative, if you have an ER positive, if you have ER negative, and all of those patients receive chemotherapy, typically either dose-dense ACT or FEC. Now, just look at the nodal status. So now, unfortunately, N1 and N2 definition is based on a clinical. So we will look at the radiology and we ask the radiologist, what do you think? This is an N1 or N2 disease? So he will tell us what he thinks. So actually, we were able to change an N1 to a complete remission in 14% of the time. Now, on the 12, there was still evidence of disease, which was large. But most of those actually were even turned out to be, actually 6 of those turned out to be a complete pathological response. So in the X-ray, the CAT scan, they look like they are enlarged. But in reality, there was no tumor. Now look at the triple negative breast cancers. So if you have a negative HER2 and a negative ER, so presume that's what we call the triple negative, and actually you can see N1 turned out to be a complete pathological response in 8. 8 out of the total, out of 11. So please, HER2, triple negative disease, send to the oncologist. Please do that. Now, can we try to predict and select the patient who's going to do well? Actually, if you look in the literature, there's people who come up with the new ideas, trying MRI and trying PET scan. Now, this probably is too small to see. Now, so actually, this is this is a small series, but actually very nice. The reason for that why it's nice, they actually did a PET scan after 4 cycles of chemotherapy. And actually, what's interesting, they said actually the one with the high PET scan, so typically this is with the high relative index, a HER2 positive disease, a triple negative. If you have an SUV more than 5.9, please consider giving a new adjuvant chemotherapy because you're going to be able to achieve some response in about 50% of the cases. So in conclusion, what I'm trying to say, new adjuvant chemotherapy has a role in breast cancers. We should understand this for multiple reasons. And the reasons include not only surgery, many other reasons too. This application in triple negative and HER2 disease, surrogate markers for response might be helpful, but we are not yet at the prime time. Now, complete pathological response need to be very carefully defined because not all complete pathological response on the same literature has been agreed upon. With this, I'll rest my case. Thank you. So, at the end, sir.
Thank you very much, Dr.
My pleasure.
Don't touch it, I like it. First of all, my name is Hemshi. I'm a member of the Saudi Society, and because I am related to these 2 people from Madina, I'd like to thank, first of all, the organizing committee,
والله من جد الحين في كان بحش.
Our next speaker is professor in radiation oncology, and he's the only professor in radiation oncology in the National Academy. Camera. And as we are working together, we're going to talk about something related to breast cancer, actually. And the big thing in this topic, when you can omit radiation therapy in breast cancer, please touch it and we'll deal with it at the end. So he's going to talk about a lot of things in radiation therapy in breast cancer. Please,
Okay, thank you, Adnan, for this nice introduction. I would like to thank Majid and Dr. Mirvat for inviting me and for the excellent organization and the hospitality. So I'm going to balance a little bit between surgeon and the medical oncology. Okay, I've been asked to touch on controversial issues related to radiation therapy in breast cancer. So I choose, for the sake of time, few things that I think it's quite interesting. I will start with some introductory slides, and then we'll see when we can omit, or if we can omit, radiation therapy in ductal in situ or in early invasive cancer. I will touch a little bit about surgical margins, because we as a radiation oncologists, we always look into this. And then the axillary lymph nodes and all the controversy, the sentinel nodes, which is better for the axilla to be treated with surgery or with radiation therapy. And as Ayman mentioned, now we are facing a lot of patients with reconstruction, different kind of reconstruction. So we need to touch on this, because it really has to do with radiation therapy also. Well, first of all, the technology of the radiation therapy had improved dramatically in the last few years. We have a lot of software technologies that allow us to really see what we are treating and how to avoid the critical structures, the lung, the heart. So you know exactly where are you shooting your beams and how you protect your critical structures. Also, the technology allow us, we have the multi-leaf collimator. You can play with this one to open and close. That will help you a lot, because typically in the past, you always end up having hot spots, large dose of radiation, whether around this area or here, and try to balance, and there is no solution. But now, with this new technology and subfields, you can achieve homogeneous dose, and that should reflect on a less toxicity and a better cosmesis. Also, sometimes we have very challenging anatomy of a patient where you cannot avoid the heart and the lung to be irradiated. But with IMRT and new technology, you really can shape your beam the way you want in most of the time. One thing, just because we're going to refer to this in the future when I talk about the axilla, when we treat the breast, when we say we are irradiating the breast with 2 tangential, this is the axillary lymph nodes, all the levels, level 1 and most of level 2 within the 2 tangential fields. So when we say we are giving only radiation field to the breast, 2 tangential, unavoidably we are irradiating level 1 and 2. And this will become important later. Of course, if we want to treat the full axilla, that will be the beam arrangement. Because when you contour this, and these are different colors to show you level 1 and 2 and 3, and this wire is around the breast. So if you are irradiating the breast, level 1 almost completely inside your field, and most of level 2. Okay, so we'll start with ductal carcinoma in situ. The main issue is the local control, and the best local control will be with mastectomy, of course. And then, because we want to preserve the breast, you can do lumpectomy, but the local recurrence will be 20%. These are average figures. If you add radiation, you can drop it to the half. For hormone, for ER-positive patients, tamoxifen will also improve the local control, and there is no survival difference along all these modalities. Basically, you are improving local control, trying to achieve what you would have with mastectomy. So is there a subgroup of patients from ductal carcinoma in situ where we can spare them from radiation therapy? There is a randomized trial, RTOG, selected the supposed to be a very favorable group of ductal in situ, very small tumors, low grade, good margin, whether to give radiation therapy after lumpectomy or just observation, and this is a 7 years follow-up. Radiation therapy improved the local control. I mean, with radiation, the recurrence was 0.9, and without radiation, 6.4. So it's still significant reduction. So you can say this is not a high figure. You can omit radiation, or you can say, well, I mean, even this figure, you can improve it to 0.9. The next one is invasive breast cancer. And we know we have the two options. The first one now is getting more popular with the reconstruction, or of course the standard conservative surgery with radiation therapy. And both options has the same, it's equivalent in terms of survival, as we know. Also, there is a randomized trial to try to see if there is a group of patients where we can spare them from the radiation therapy. This is the PRIME2 trial. They also selected a favorable group of patients, elderly patient, more than 65, and all hormone positive, node negative, clear margin, and it's quite a good number of patients. They have conservative surgery, and they started them on hormonal therapy, and randomization whether to go with whole breast radiation or no radiation. And the local recurrence without radiation, 4%, is very small. With radiation, it dropped 0.3. There is no survival difference. Also, there is another randomized trial, came almost to the same conclusion that radiation therapy, the absolute reduction is only 3%. The author, they interpret this, that this is a very small benefit of radiation therapy, because 4% local recurrence is a very small figure. It can be acceptable. I think the bottom line, if a patient is elderly and she has other comorbid disease, or you have a situation, there is a case that you can make a case of not giving radiation therapy to this group of patients, because without the radiation, the local recurrence is only 4%. Although radiation will improve it, but it's already too good. I mean, you can interpret this data the way you want. Okay, talking about the margin. Positive margin is very simple, that you have ink on tumor, whether this is invasive or inside. If the pathologist, the tumor is at the ink, this is positive margin. There is no tumor at the ink, there is negative margin. This is very important. When you have tumor at the ink, this is very important in terms of the local recurrence. Okay, it doubles your local recurrence. Twofold increase in the ipsilateral breast tumor recurrence. This is regardless whether you give radiation boost, you give systemic treatment, favorable biology. The fact that you have tumors at the ink, this will double the local recurrence. We cannot fix with radiotherapy positive margin, or if you have tumor at the ink. If you have tumor at the ink, you have to take this patient back to have a negative margin. Radiotherapy with boost, it will improve the situation, but it will never be like margin negative patient. So basically, margin negative patient, you don't have tumor at the ink, whether invasive or in situ. How wide is this margin should be, the negative margin, is controversial, but most of the centers now, they accept 1 millimeter margin for the invasive and maybe 2 millimeter for the in situ. Trying to obtain more than 1 millimeter margin, it will improve the local control very little, not justifying taking the patient routinely to OR to have a wider margin. If you don't have tumor at ink, I don't think this patient should go back just to obtain a wider margin. So I think from the clinical point of view, in terms of the decision, the term, what we used to say, close margin, I think it will be deleted in the future, because either you have tumor at the ink or you don't have tumor at the ink. Okay, now we come to the reconstruction. We are seeing a lot of patients now with reconstruction. And this is quite challenging from the radiation therapy point of view. Of course, I'm in touch on this. You have either immediate reconstruction, you can do it in the same setting, the same surgery, which is very good psychologically to the patient, or you can delay it after the patient complete the chemo, the radiotherapy. Later on, you refer her to the plastic surgeon to take care of this. This is in terms of timing. In terms of the options you have, as it's been mentioned, either you have a permanent implant, immediately you can put, or you can put a tissue expander, and then you expand it, and then you replace it with the implant. And here, from the radiotherapy point of view, you can give the radiation to the expander, or you wait till you have the implant and then you irradiate the implant. Or you can have autologous, whether tram or any of the options, autologous tissue. Unfortunately, radiotherapy will do bad things for whether it's a tissue expander or implant, or it's a auto like tram or something. You have all these potential could happen to the implant as a result of the radiation therapy in about 30% of the patients. And also, if you irradiated a reconstructed auto tissue, you could have any of these like fat necrosis or shrinkage or distortions. So radiotherapy may do some harm whether the patient chooses this way or this way. In terms of the timing of the radiation therapy, طبعا it depends on the center. Different centers and different teams and tumor boards, they have different options and has to be coordinated, like it's been mentioned by Khalid. But one of the options that they do mastectomy and they put the expander, and then during the chemotherapy they inflate the expander, okay, and then they replace it with the implant, and then you give the radiation to the implant. Or you can move the radiation here, you irradiate the expander, and then they replace it with the implant. All the options is there. So the question would come, which is better, to irradiate the permanent implant or to irradiate the tissue expander? Some data is studied that showed it's better to irradiate the implant. If you irradiate the implant, only 7% the implant failure. But if you irradiate the tissue expander, it will be higher, because then they will use irradiated tissue to take this out and to put the new one. Of course, no radiation will be better. So if you are irradiating a tissue expander, okay, wait at least 6 months before you exchange it with the permanent implant. If you do it earlier, then you will have a higher chance of failure. From the irradiation, the technical point of view, sometimes it's quite challenging to irradiate an implant. If this patient had an implant here, usually it's very easy. 8 patients like this. Maybe what they say, the Angelina effect or whatever, that we have implant both sides. She doesn't have cancer both sides, but at the same setting, they did both sides. It's quite challenging because maybe this will, when you give the radiation, this will be challenging with the traditional fields because part of the other breast will be irradiated. There is a way around it with IMRT and so on. But also, just to tell you that from the radiotherapy point of view, could be challenging. Luckily, like for example, Ayman, he rarely do the operation before consulting us. He called me like, I have this patient, I'm planning to do so and so. It's very important that you consult the other colleagues before you go ahead with any decision. So maybe the recommendation, and this is personal view, regarding the reconstruction and radiation therapy, if you have a patient with locally advanced tumor or positive lymph node to start with, this patient guaranteed will end up having radiation therapy. It's better not to do immediate reconstruction. It's better to let the patient finish the chemo, the radiation, and then later on, preferable after 1 year, you do whatever reconstruction you want to do. If you have an early stage cancer, I think the psychology is very important. If you can afford OR time and so on to do immediate reconstruction, I think you should go ahead with that. This generally speaking, if you want to choose between auto or implant, from the radiotherapy point of view, we prefer auto. It withstands the radiotherapy toxicity better than the implant. but you have to consider the patient choice and other factors. This is just from the radiotherapy point of view. Okay, I think all the previous speakers, they touched on this picture. We don't want to see it. We still see this lymphedema that has no treatment. We just try to convince patients to keep doing physiotherapy. It's quite morbid. I think it's a disease by itself. Okay, and it's directly correlated to axillary dissection, and the more lymph nodes, we used to evaluate surgeons by how many number of lymph nodes he removed. But now things change, as you know. The whole issue about the axilla is a local control of the axilla, not survival benefit or anything. So because we are trying to improve the control in the axilla, we are doing all this. Okay? I want you in the coming few slides to focus on the figure, what is the percent of the axillary recurrence that we are so worried about it. It's very, very low. Okay, there is two big trials that change basically the management of the axilla, and I'm sure all you know about it. The Z11, we know, down the standard is central lymph nodes. If it's negative, this is the end of the story. We are talking about central node positive patient. This trial randomized patient, if they are positive, whether they continue axillary dissection or nothing, no further axillary dissection. But this one addressed a different question, that if it's positive, either they go for axillary dissection or radiation. So this one, no radiation, this one radiation. So this study, they do the central lymph nodes. If it's negative, this is the end of the story. If it's positive, then either they continue axillary dissection or no axillary dissection. It's very important to know that those group who went for axillary dissection, they found in 27% more positive lymph nodes. This is a very important figure. If a central lymph node positive, if you continue with axillary dissection, almost 30% you will have more positive lymph nodes. But to me, what's more important is those group who did not have the axillary dissection. So theoretically, we left 27% positive lymph nodes. See how much the axillary recurrence is 0.9. You would have expected 27% to have axillary recurrence. But this is not true, because these patients had systemic chemotherapy, they had other kind of radiation and so on. So you are so worried about doing axillary lymph node dissection because you want to take out the more positive lymph nodes, which is still inside. Who cares? Then if this patient is going to have chemotherapy, the axillary recurrence is very small, even if you leave positive lymph nodes. I'm talking about clinically negative patients, not big nodes or extra node or anything. So this study basically is a quite favorable group of patients. The excluded patient is very important. The excluded patient that had matted lymph nodes or extra nodal extension or big ones, we're talking about favorable axilla. There is no difference, and the axillary recurrence was 0.9% versus 0.5%. So even those who had axillary dissection, the axillary recurrence is 0.5%, it's not zero. So you see how much you improve the axillary recurrence, but if you remember the picture of the lymphedema, it's not worth it. No survival difference. I bought this one because many times when I mention about this study, they said it's closed early, did not initially accrue the goal of the number of patients. Very low event. Recruiting more patients is not going to change the outcome. So the conclusion of this trial for clinically negative patients, okay, if they have 1 or 2 central lymph nodes, microscopical disease, and the patient is going to have radiation and chemotherapy, routine use of the axillary lymph node dissection is not justified, not justifying to have this. The other trial, after the central lymph nodes, if it's negative, this is the end of the story. If it's positive, they get randomized to dissection or radiation. Okay. Luckily, in this in this trial, they included patients with more bad prognosis. So they have up to 3 positive lymph nodes. And some patients had mastectomy, and some patients had macroscopic metastasis in the sentinel lymph nodes. So it's not a very favorable group of patients. And they randomized them to have either continuous axillary dissection or radiation. If those who had dissection had 4 or more positive lymph nodes, they had adjuvant radiation also. So 5 years follow-up, see the axillary recurrence, 0.5% in favor of surgery or 1%. We are talking about very small axillary recurrence. Okay, no survival difference. But it's very important to know this figure. The group who continue for surgery, 28% the lymphedema in the study. And the group who had radiation therapy is 14%. So treating the axilla with radiation will give you less lymphedema. Thank you.
Thank you very much, Dr. Adam. We are going exactly with the time. And next speaker will be
عارف هذه؟ لا كاميرا مش ميكروفون.
لا ما ابغى كاميرا بس بايظ حلقتين بعدين
حطيتها اديته هنا اديته حالنا
لا maybe this one is this
what is this slides?
What is mine?
حطيتها اديته هنا
I think is it this one or this is yours?
معي من بداية الأسبوع
يمكن يحطها هنا هذه مثلا. Where how to move these sides? I think this one. Yeah, خلاص okay. Okay. بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. So first of all, I would like to thank the organizer and the scientific committee for inviting me to participate in this meeting. And I have been tasked over the next 20 minutes or so to discuss with you the primary adjuvant chemotherapy, what is the best in 2015. So my talk outline, so first I will talk about which patient should receive adjuvant chemotherapy and which patient we can avoid chemotherapy. And then we will talk about what is the best chemotherapy regimen in 2015, and we will end up with the future challenges. So let us start first with which patient should receive adjuvant chemotherapy. So suppose that you have a 50-year-old female patient, premenopausal. She was diagnosed with ductal invasive carcinoma. She has tumor size of 2.2 centimeter, node negative. She has high-grade histology, and she has triple negative disease. So I think that this patient is a good candidate for adjuvant chemotherapy, and I think that the majority of you would agree that this patient is a good candidate for adjuvant chemotherapy. Is the voice